Okay, this is Kayafji, and I'm taping the lecture for Learning Plan 8, which is the nursing care of patients with alterations in their genitourinary system. Um, if you go to your PowerPoint slides on the Blackboard website and you open them up on your computer, there's a link to a renal function video and a urinary system video for review. If you'd like to review the anatomy and physiology of the urinary system, I would highly recommend that you go to those links. They're just real short videos, but they're very informative. Here we have the structure of the urinary system, the kidneys. Excuse me just a second. Straighten that out. Okay, the kidneys, ureter, urinary bladder, and urethra are structures of the urinary system. The kidneys, you see, are bean-shaped organs positioned on either side of the vertebral column at the first lumbar vertebrae. The left kidney is slightly higher than the right. Then the urine is carried by the ureters from the kidney to the bladder through peristaltic action. The bladder is a hollow muscular organ. It serves as a reservoir for the urine. The inner lining of the bladder is a mucous membrane. The urine passes from the bladder, then down the urethra, and then the internal involuntary urethral sphincter is controlled by the detrusor muscle that is in the wall of the bladder. The external urethral sphincter voluntarily controls release of the urine to the outside, and then blood is brought to the kidney by the renal arteries that branch off the aorta, and blood is returned from the kidneys via the veins to the inferior vena cava. The kidney consists of the cortex, the outer layer, the medulla, and the renal pelvis. The cortex contains blood vessels and nephrons. The medulla contains the collecting tubules, and the renal pelvis gathers the urine and directs it to the bladder. The nephron is the functional unit of the kidney. There are about 1 million nephrons in a kidney. The nephron consists of the glomerulus, which is a network of capillaries that are encased in a thin wall sac called the Bowman's capsule, and the tubular system. The tubular system of the nephron consists of the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. Then the urine is then carried by the ureters from the kidney to the bladder. We kind of talked about the sequence of actions in the last slide. Okay, here we see a picture of a nephron. Again, it is a unit of the kidney. There are about 1 million of these located in the kidney, and it's a tiny filtering structure that helps to remove excess water, waste, and other substances from the blood. It also returns substances like sodium, potassium, or phosphorus whenever any of these substances are running low in your body. Each nephron is composed of 2 main structures, the glomerulus and the renal tubule. The glomerulus is consisted of a tiny blood vessel or capillary. It kind of looks like a ball of yarn. It's looks kind of twisted and turny. And this is where the actual filtering of the blood occurs. Each glomeruli acts like a sieve and helps to keep normal proteins and cells in your bloodstream and allows waste, excess fluid, and other substances to pass out of the bloodstream. The tubule is a tiny tube where the waste and extra fluid and other recyclable substances like sodium and potassium are filtered out from the glomerulus pass through. Your kidneys kind of measure out the chemicals like sodium, phosphorus, and potassium and release them back to the blood to return to the body if the need arises. In this way, your kidneys regulate your body's level of electrolytes. The right balance is necessary for the body to function properly. Let's look at the changes that occur to the kidney with aging. Kidney function begins to lessen after the age of 45, and renal blood flow and GFR gradually decrease to about half the rate of a young adult by the age of 65. In a male, the prostate gland hypertrophies and with age and can cause degrees of obstruction to the normal flow of urine. And secretion of renin and aldosterone and vitamin D activation are also decreased. Degenerative changes in the bladder muscles may lead to residual urine, or otherwise known as incomplete emptying of urine, and the urinary incontinence or involuntary passing of urine can also occur. Bladder capacity decreases to as little as 200 milliliters and frequent emptying is necessary. Kidney also has a decreased ability to concentrate urine, which leads to nocturia or needing to urinate during the night. Lowered estrogen levels in women result in tissue atrophy in the urethra, vagina, and trigone of the bladder, the triangular portion at the base of the bladder, which predisposes to infection and incontinence. Okay, let's take a look at the diagnostic tests that are done to evaluate the effectiveness of the urinary system. Okay, first of all, we'll look at the urinalysis. A urinalysis is just a sample of urine that can examines the urine, and it can pretty much determine the general health of the body, and specifically the kidney function. It's usually used to measure the pH of the body. It can test for proteins. It can test for glucose, ketones, and blood. It looks at bilirubin, if that's being secreted by the kidneys. It'll also tell us if there's any presence of bacteria. If there is a presence of bacteria, then the healthcare provider would order a culture and sensitivity. The urine would be cultured, and then any pathogen or bacteria that's identified would then have a sensitivity run on it, where the bacteria would be exposed to different types of antibiotics, and then the physician or healthcare provider would determine which would be the safest and best antibiotic to treat the infection. A complete blood count is done to determine usually if there's an infection going on. They'll look at the white blood cell count, and that would be elevated. If the patient has kidney disease, and it's not manufacturing erythropoietin, which is an important hormone to stimulate red blood cell production, you may see a reduction in red blood cells and hemoglobin level. The blood urea nitrogen is a product of when urea is produced when protein breaks down, and it combines with ammonia and is carried by the bloodstream to the kidneys for excretion. Um, Creatinine is a byproduct of skeletal muscle contraction as well. So the BUN and creatinine are usually interpreted together to determine the function of the kidney. So the complete blood count and the blood urea nitrogen level and the creatinine are usually blood tests. Then there's a test called a creatinine clearance, where the patient's urine is collected for a 24-hour period. And then a 5 milliliter venous blood sample is also collected during that 24-hour period. Then the serum creatinine and the urine creatinine results are compared. If the serum creatinine level is elevated and the urine creatinine level is decreased, that would indicate that there's decreased kidney function, because the kidneys should be filtering that creatinine out of the bloodstream. So if the level in the bloodstream is elevated, then and the urine creatinine is low, then we know that the kidneys aren't functioning the way they should. Another test that can be run is a cystatin C, and that's used to evaluate glomerular filtration rate. Cystatin C is a low molecular weight proteinase inhibitor that's produced at a constant rate and filtered out by the glomerulus. During impaired kidney functions, cystatin C levels will rise. This diagnostic test may be a better indicator of GFR when measured with a serum creatinine if the patient has chronic kidney disease. Okay, occasionally a healthcare provider will look at the ratio of a person's BUN and their blood creatinine to try and help determine what's causing concentrations to be higher than normal. So the ratio of BUN to creatinine is normally between 10 to 1 and 20 to 1. An increased ratio may be due to a condition that causes a decrease in the blood flow to the kidneys, such as congestive heart failure or dehydration. It may also be seen with increased protein from GI bleeding or increased protein in the diet. The ratio may be decreased with liver disease due to the decrease in formation of urea and also from malnutrition. An X-ray such as a kidney, ureters, and bladder X-ray, or KUB, is used to locate kidney stones or to detect structural abnormalities. So the patient would receive an injection of a contrast. So it's important to check for allergies prior to sending the patient down for the X-ray. Make sure they're not allergic to iodine or shellfish, things like that. And then they just have a basic X-ray done, that determining where the contrast is located. And as I said, it will help to detect if there are any structural defects or kidney stones. Angioplasty is a surgical procedure that's used to open up blocked vessels and increase blood flow to the kidneys. And then urodynamic testing is used to measure the flow, volume, and muscle function of the urinary system. Biopsies of the kidneys or bladder are sometimes done in combination with the radiological exams to locate any lesions in the kidney. The clean catch method is used to avoid contaminating urine sample with bacteria that are normally present in the urethra and appear in avoided urine sample. So it is used for especially urine cultures or other urine tests that require that the sample be sterile. as sterile as possible. With the aging kidney, so for the elderly, the aging kidney has less ability to concentrate urine, so this predisposes the patient to dehydration if fluid intake is restricted for diagnostic tests. Also, the contrast agents used for X-rays in conjunction with the dehydration can cause acute renal failure in your elderly patient. The nurse should carefully rehydrate the patient by encouraging several ounces of oral fluid, if possible, every 1 to 2 hours, and monitor vital signs, urinary output, lung sounds, and respiratory effort to prevent fluid volume overload. A 24-hour urine collection is usually started in the morning. We have the patient void and discard that first urine, and then we note the time that the urine test is started, and then we save each successive voiding into a collection container. At the time when the test is to end, the patient voids again, and this last void is added to the urine collection bottle. It's always important to check with the lab to determine if the container has to be kept on ice or in a refrigerator. It's often a good idea to place a sign in the patient's bathroom stating that there's a 24-hour urine test in progress, so all staff know to save the urine properly. Okay, just a review of some of the hormones and metabolic actions associated with kidney function. Again, aldosterone is circulating in the blood, helps to influence urine volume and concentration. It increases the reabsorption of sodium. The antidiuretic hormone increases permeability in the tubules and the reabsorption of water. The atrial natriuretic hormone increases the secretion of sodium as produced by the kidney. Erythropoietin stimulates the bone marrow to increase red blood cell production. Increases production of erythropoietin is triggered by the demand for oxygen, and when red blood cell levels fall below normal. Calcitrol increases the absorption of calcium and phosphorus. Renin assists in the regulation of blood pressure. The parathyroid hormone works in conjunction with calcitrol to increase absorption of calcium and phosphorus, and cortisol promotes sodium and water retention. Here are some examples of potentially nephrotoxic substances. First of all, anti-infectives such as aminoglycosides, sulfonamides, antifungals, cephalosporins, tetracyclines can cause kidney damage. ACE inhibitors such as captopril, anti-neoplastic agents, immunosuppressants, non-steroidal and anti-inflammatory drugs such as salicylates or ibuprofen, and other drugs such as acetaminophen, furosemide, cimetidine. Also, we look at other toxic substances. We're going to go to the next slide for this one. Contrast media, such as gastrografin, anesthetics, heavy metals, exposure to industrial chemicals such as carbon tetrachloride, environmental exposure to pesticides, and then also recreational drugs such as cocaine or heroin. So let's take a look at this question. The decrease in secretion of renin, aldosterone, and vitamin D causes excretion of sodium, dilution of urine, increased intestinal absorption of calcium, increased bone density, or decreased thirst. So take a moment to just think about that and select your answer. Okay, so the answer to this question would be 1, 2, and 5. Okay, let's look at this one. Preoperative care of the patient about to have a renal biopsy includes administer bowel preparation, report abnormal coag studies, enforce NPO for 6 to 8 hours before the procedure, check for allergy to iodines, and insert indwelling catheter. So to do a renal biopsy, so we're going to biopsy a kidney, what would we do? We would do number 2, because the patient would be at risk for bleeding if they have abnormal coagulation studies, and also we would enforce number 3. The patient would need to be NPO for 6 to 8 hours prior to the procedure. Okay, so now we're going to look at the nursing management of a patient with GI issues, or excuse me, with GU issues. So first of all, the nurse would do an assessment and they would look at the history. At the time of admission, the nurse would obtain a personal history of any previous disorders in the urinary tract, such as frequent urinary tract infections, any illness or injury to the urinary system, or any problems that would have required surgery. You look at family history of diabetes, cardiovascular disease, or kidney stones in our assessment relevant to the kidney function. There are substances that could be considered toxic to the kidney, so the nurse would obtain the patient's history about their use of medications, either prescription or over the counter, or any illicit drugs, or any occupational exposure to hazardous materials. So a complete drug history would be taken at the time the patient was admitted or seen. Then the nurse would conduct a focused assessment by inspecting the abdomen for any visible abnormalities, palpating all 4 quadrants to determine if there's any areas of tenderness, palpate above the pubic bone for any evidence of bladder distension, inspect the genitals, report any bleeding or discharge present of recent discontinuation of an indwelling catheter, and then examine the urine for color, clarity, volume, and smell. Nursing responsibilities on an ongoing basis would be to measure intake and output, to evaluate any abnormal flow of urine, note the characteristics of the urine, color, odor, clarity, aroma, notice any changes in pattern of voiding, and then assessing any pain or discomfort with urination. Let's take a look now at the terminology that's used in relationship to urine output and flow. First of all, anuria is an absence of urine. It may be associated with acute renal failure. Oliguria is diminished or abnormally decreased flow of urine. Could be as a result of dehydration or renal failure or an obstruction. Polyuria is the abnormally high and dilute urine output. It's a result of excessive solutes and increased excretion of water. Can be caused by hypercalcemia, diabetes insipidus, or uncontrolled diabetes. Nocturia is urination that occurs during the night, usually as a result of the aging kidney to concentrate urine. So there's a decreased ability of the aging kidney to concentrate urine. And then urinary frequency is voiding more often than every 2 hours. Can be a result of inflammation, decreased bladder capacity, pregnancy, increased fluid intake, or psychological disorders. Urinary hesitancy is a delay in starting the stream, could be as a result of a partial obstruction. Urinary retention is the retaining or holding of urine in the bladder. Could be caused by a psychological condition, neurologic condition, medications, or obstruction. And then residual urine is that which is left in the bladder after voiding. Could be related to poor muscle control or partial obstruction. Okay, common causes of variation of color of urine. You may see colorless or pale yellow urine. It says it could be as a result of diuretics. Also, diabetes insipidus, overhydration, chronic renal disease. You see a bright yellow urine. Could be caused by multiple vitamin intake. Dark amber to orange urine can be caused by pyridium medication, or because concentrated urine is being formed because of dehydration or as a result of a fever. Pink to red color urine can be caused by medications such as compazine or doxates calcium. May also indicate that there's fresh red blood cells in the urine, or it can be as a result of menstruation or foods such as beets, blackberries, or red food dye. Brown color urine can be as a result of flagell, or in some cases it can be a result of extremely concentrated urine because of dehydration, old red blood cells in the urine, bilirubin in the urine. Then blue or green color urine can be as a result of dirinium medication or methylene blue that's used in diagnosing bladder urinary problems. It can also be as a result of a Pseudomonas infection. And then dark brown to black urine can be caused by certain medications such as macrodatin or iron preparations. Or it can be a sign of a tumor or Addison's disease. Or again, old red blood cells in the urine. Besides the color of the urine, other characteristics are also noted. If there's an unusual odor, like a foul smell, may indicate infection. Hematuria, it means that there's blood in the urine. So then it would be more of a kind of a reddish to, if it's a bright red blood, fresh bleed, it would be red. If it's old blood, then it would be more of a rusty color. Protein in the urine is usually determined by a urine test. Proteins are too large to pass through the structure of the glomerular membrane, so if there's a presence of protein in the urine, that means that there's damage to the membrane that occurs in renal disease. It can also be seen in conditions such as preeclampsia, multiple myeloma, and diabetes. Pneumaturia means that there's gas in the urine. So it would be, bubbly. This can occur if there's a fistula between the bladder and the bowel or the vagina. And then we would also evaluate if there's any changes in voiding pattern. So do they have urinary frequency during the day or at night? Is there any alteration in the size and force of the urinary stream? Any feeling of fullness even after voiding? And any change in the amount of urine passed each time the patient voids? Increased frequency can be a result of a problem in the urinary system, particularly in the bladder and the urethra. So frequency with which the person feels the urge to urinate can be related to psychological as well as physiological factors. So if the person is anxious or fearful or excited, that may increase their need to urinate. Caffeine and other diuretics also can increase the number of times that a person must void. Pathological conditions that cause increased frequency include inflammation of the bladder, otherwise known as cystitis, or inflammation of the urethra, known as urethritis. Okay, for pain and discomfort, we would assess location and occurrence of this discomfort. Bladder pain is caused by the stretching of an overfull bladder. So the nurse would assess the size and location of the bladder. Normally, the bladder should not be felt. So if you feel a smooth, rounded mass upon palpation above the pubic bone, that means that the bladder is distended. Bladder pain can also be caused by spasms of the bladder muscles as it attempts to empty itself of clots or tissues, bits of tissue, or other cellular debris. And it can occur postoperatively if there's inflammation or bleeding in the urinary tract. Flank pain, which is defined as side and back area of the body below the ribs and above the hips, is caused by obstruction and distension, usually indicative of a kidney stone. And then dysuria is the pain that's caused by inflammation in either the bladder or the urethra and occurs with urination. It's often described as burning and can range from mild to severe. Fatigue and irritability are often common when kidney function is impaired because of the buildup of waste products in the body and their effect on body cells. So nursing diagnoses that are frequently associated with urological problems and disturbances in urinary flow include the following: impaired urinary elimination related to inflammation, urinary retention related to removal of an indwelling catheter, excess fluid volume related to inability of kidneys to produce urine, and pain related to ureteral spasm, bladder spasm, or inflammation. More diagnoses are fatigue related to accumulation of waste products, deficient knowledge related to prevention of urinary tract infection, fear related to cause of hematuria or possibility of malignancy, and disturbed body image related to urinary diversion. General nursing goals are absence of infection, absence of pain, restoration of normal urinary output, return to normal fluid balance, a simulation of knowledge for appropriate self-care, promoting resolution of body image disturbances, and prevention of complications. We would monitor intake and output, body weight, and signs of edema, monitor drug combinations for potential nephrotoxicity and possible urinary retention. We would maintain strict aseptic technique in urinary catheter care. As far as legal and ethical concerns, urinary catheters are one of the most common causes of healthcare associated infections. In 2011, there were over 93,000 urinary tract infections in hospitalized patients, and 75% of those were catheter related. So alternatives to catheterization should always be considered to prevent infection, and the care should be carefully documented. If a patient dies of a healthcare associated infection, the death is investigated to determine how the infection developed and contributed to the death of the patient. The purpose of the investigation is to prevent future incidents. Medicare and the National Patient Safety Goals have set as their goal to reduce catheter-associated urinary tract infections, otherwise known as CAUTI or CAUTI, to protect patients and decrease the occurrence of urinary tract infections related to the use of Foley or urinary catheters. At this time, I'd like to direct you to page 779 of your textbook, box 33-3, where it lists the principles of urinary catheter and tube care. You can put this lecture on hold while you review that information. Okay, here you have a picture that's listed in your book, figure 33-5, page 778. It discusses or shows that the catheter should be fastened to the upper leg with tape or a catheter securing device. The connecting tubing should be positioned so that there is no pulling on the catheter when the patient turns or moves in bed, and it prevents pulling on the balloon that holds the catheter in place, which could cause tissue irritation and predispose the patient to infection. Okay, now I'll just go over a couple of more common urological problems. First of all, we'll talk about urinary incontinence. Contributing factors in pathophysiology, they found that people who are institutionalized have a higher incidence of urinary incontinence, and it's the leading cause of admission to a long-term care facility. Other contributing factors are women who've had several children may have anatomic changes that make incontinence more likely. Men may experience problems because of an enlarged prostate. And other contributing factors are spinal cord injuries, neurological disorders such as dementia, or functional disorders such as difficulty manipulating clothing fasteners. When incontinence is occurring, the first step is to identify the factor that's contributing to the incontinence. Immobility, urinary tract infection, urethritis or vaginitis associated with menopause, could be related to a stool impaction, prostate surgery, confusion, some endocrine problems, and various types of medications such as beta-adrenergic or calcium channel blockers. Obesity can also be a factor because of the pressure it places on the bladder. There are different types of incontinence. Urge incontinence is the involuntary loss of urine when there is a strong urge to urinate, otherwise known as urinary urgency. Stress incontinence occurs when the urethral sphincter fails and there's an increase in intra-abdominal pressure caused by things such as sneezing, laughing, coughing, or exercising. Mixed incontinence is a combination of the different types of incontinence, such as stress and urge incontinence. Overflow incontinence occurs when there's a poor contractility of that detrusor muscle on the bladder, or an obstruction in the urethra, such as a prostate enlargement in males, or a genital prolapse in the female. Functional incontinence is caused by cognitive inability to recognize the urge to urinate, or a self-care deficit caused by extreme depression. Inability to reach the bathroom because of restraints, side rails, or an out-of-reach walker can also result in functional incontinence. And then neurological incontinence is caused by disorders of the neurological system such as multiple sclerosis or spinal cord injury. Diagnosis of incontinence is based on careful history taking and patient report of symptoms. The patient may be asked to keep a bladder diary, so that would record when the incontinences are occurring. Routine urinalysis is also performed to determine if there's any infection or anything like that going on. When conservative measures don't improve continence, then the healthcare provider can choose to evaluate the condition with a series of diagnostic tests, such as measuring the post-void residual volume, stress testing of the urinary system, urodynamic studies, a cystogram, or cystoscopy. Treatment. Evidence-based practice indicates that stress incontinence occurs with exercise, laughing, or coughing, and that may be corrected by exercises to strengthen the pelvic floor muscles. So vaginal weight training with a set of 5 small cone-shaped weights that are used along with pelvic muscle exercises is a therapeutic option for incontinence. The lightest cone, which has a string attached, is inserted into the vagina and held in place by muscle tightening for 15 minutes twice a day. When there's no problem holding this cone in place, then the next heaviest cone is used, and this continues until the heaviest cone can be held in place for 15 minutes. Maintaining normal weight and using topical estrogen therapy after menopause also decreases the incidence of this disorder. Other medications have been found to be helpful in treating incontinence. If you look at table 33-5, it provides information about these selected drugs for urinary incontinence. So that would be on page 782 of your textbook. Bulking injections into tissue surrounding the urethra are an option as well. An old assistive device such as a pessary or a stiff ring that is worn in the vagina during the day to support the bladder is also done, but there are newer treatments for overactive bladder and problems like that, such as Botox injections. Further treatments for urinary incontinence could be biofeedback therapy or an implanted electrical stimulation device called an interstim. There are also clamp-type devices that can be used across the penile urethra. Transvaginal electrical stimulation, otherwise known as TES, stimulates the nerves and muscles of the pelvic floor by an electrically charged probe. Stimulation is done in 2 15-minute sessions twice a day for 12 weeks. And then finally, surgery can be done to correct incontinence. Surgeries that are most often done in women are retropubic suspension. The procedure is performed to correct a cystocele or prolapse of the bladder into the vagina and urinary incontinence. A low abdominal incision is made and the urethral position is elevated in relation to the bladder. The urethral and suprapubic catheters are in place for several days post-op. For a pubovaginal sling placement, a low transverse incision is used to correct stress incontinence in women. There's also an artificial sphincter implant that's used commonly to correct incontinence for males, where a mechanical device is placed around the urethra to open and close it. If these surgical measures don't solve the problem, then incontinence is often managed by intermittent catheterization or indwelling urethral catheterization. In some instances, a suprapubic cath or an external collection system such as a condom cath could be used. Okay, nursing management of incontinence. Of course, the nurse would use a gentle and matter-of-fact approach when taking an incontinence history. Evidence-based practice supports the use of protocols and guidelines for screening for urinary incontinence. The patient experiencing urinary incontinence may be embarrassed by the symptoms. Observe for clothing stains and odors and perform a general physical assessment that includes palpation of the bladder. If you're assessing an older adult, assess them for gross motor strength, fine motor dexterity, and ability to balance and independently ambulate. That will help you determine if they're at risk for functional incontinence. If the incontinence is not corrected by fixing an underlying cause, then attempt to help the patient set up a voiding and fluid schedule. Assess when the patient is experiencing incontinence. A useful tool is having the patient keep track of their voiding pattern by completing a voiding diary. So we want to assess the pattern of incontinence and instruct the patient to keep the diary. Then assist or remind the patient to go to the toilet at set times, just before the time when the incontinence usually occurs. Space fluid intake and give most fluids during the day. Discourage intake of bladder stimulants such as alcohol and caffeine. Help the patient ambulate at least 10 minutes, an hour, or two before bedtime because activity helps to mobilize fluid. They may have a condom cath applied for males or a moisture-proof pad or pants for women at night because it's not practical to continue a voiding schedule every 3 to 4 hours at night because that would disrupt their sleep. And then give positive reinforcement for any small successes. So let's take a look at this question. Which nursing interventions are appropriate for a patient with stress incontinence? Select all that apply. Instruct patient in a voiding diary. Keep or teach Kegel exercises. Offer assistance every 2 hours. Obtain bedside commode as needed. And teach to avoid bladder irritants such as coffee and nicotine. And the correct answer for this question is 1, 2, and 5. The next problem we'll look at is that of urinary retention. Urinary retention is retaining or holding urine in the bladder. It can be either acute after a surgical procedure or after an indwelling catheter has been removed, or it can be chronic, related to anxiety or neurological disorders or obstruction of urinary flow. A straight catheter is used for a single in and out catheterization for temporary inability to empty the bladder. Patients who have permanent paralysis may use intermittent catheterization as well to empty their bladder. Urinary incontinence will not cause the bladder to rupture, but urine will begin to dribble out of the urethra. Retention of urine stretches the bladder walls, causing extreme discomfort. Assess the degree of bladder distension using gentle palpation before and after an intervention is performed. So before you would insert or do a straight single in and out catheterization, you would assess bladder for distension. Provide privacy and adequate time for voiding efforts. A caffeinated drink followed by a warm bath may be helpful. Instruct the patient in the double void method. Instruct the patient to void, then sit in the toilet for several minutes and try to void again. Also, we try scheduling a trip to the toilet every 3 to 4 hours. We may need to obtain an order for catheterization if these methods don't relieve the problem. There are medications for urinary retention such as bethanechol. If you see table 33-5, which is on page 782. They list many of the different drugs commonly used to treat urinary incontinence and retention. So let's take a look at that. Poor bladder tone or partial obstruction of the urethra can result in dribbling of the urine or passing only the overflow. So the bladder is still partially full. So during bladder retraining, you may need to check residual urines, and that can be measured by having the patient void as much urine as possible, and then either performing a bladder scan or immediately inserting a straight cath in and out to measure residual. 100 milliliters is considered a normal amount of residual urine. Any more than this can become concentrated over time, predisposing the patient to bladder infection or the formation of stones.